Welcome back to the Talking Ketamine podcast. This is episode 64, Ketamine Therapeutic Guidelines.
So you know how ketamine therapy is becoming more common for depression? But it can feel a bit like the Wild West out there. Well, a group of experts just published some much-needed guideposts to help keep things safe and effective.
Yeah, exactly. And for anyone listening who's been following this space, it really does feel like navigating without a map right now.
Right.
I mean, you can basically walk into a strip mall, hand over your credit card, and get an injection of this really powerful dissociative anesthetic that, was originally used on battlefields.
Which is wild when you actually think about it.
It really is. There's no centralized map, no universal rules. So our mission today is to unpack the GPS that just dropped to fix that.
The new guidelines.
Right. The American Society of Ketamine Physicians, Psychotherapists, and Practitioners, or ASKP3 for short, just released their official rules for intravenous ketamine. We want you, the listener, to understand exactly how these parameters impact your access to safe, scientifically grounded care.
Yeah, and it's so important because we are seeing an absolute explosion in demand for this treatment.
For sure.
People who have struggled for decades with treatment-resistant depression are reading about these incredible outcomes, and clinics are just materializing seemingly overnight.
Right. They see the headlines and they want in.
Exactly. But the foundational issue driving all this chaos is the term off-label.
Right.
Ketamine is fully FDA approved, but it's approved as a high-dose anesthetic for surgery, not as a low-dose psychiatric intervention for depression.
Well, I assume off-label just means unapproved for that specific use, which, doctors do all the time.
Sure they do.
People take blood pressure medication off-label for anxiety, and it isn't treated like a crisis. So what exactly are the real-world dangers for patients when clinics operate without standardized protocols for ketamine?
Well, it really comes down to the sheer physiological and psychological power of the drug. Like with blood pressure medication, the side effects are usually pretty mild.
Right, maybe you get a little dizzy at home.
Yeah, exactly, and it's manageable. But ketamine fundamentally alters your cardiovascular function and your consciousness in real time.
Wow, okay.
Physically, it can cause these transient, but sometimes very severe spikes in blood pressure and heart rate. And psychologically, it pulls the patient into a non-ordinary state of consciousness.
Which is no small thing.
Not at all. In the worst-case scenarios of this Wild West, you have clinics operating more like wellness spas.
Oh, right.
They offer a comfortable reclining chair and some nice aromatherapy, but they completely lack advanced cardiovascular monitoring or trained psychiatric support.
So if something goes wrong.
Right. If a patient experiences a hypertensive crisis, which is a dangerous spike in blood pressure, or they slip into a terrifying state of severe dissociation, a spa attendant cannot manage that.
They just don't have the training.
Exactly. The danger is a completely destabilized patient who came in desperate for healing and actually leaves traumatized.
Which means we needed a standard rule book, like yesterday. And that leads us to the ASKP3 and how they went about building this framework. They recognized the vulnerability in the system and brought together an interdisciplinary committee to create these safety nets.
Right.
But they didn't just sit around a boardroom table and vote by raising their hands. They used something called the Delphi method.
Yeah, the Delphi method. It's a really rigorous, iterative process designed to eliminate bias and ego.
Okay, how does that actually work in practice?
So rather than putting a dozen strong personalities in a room where the loudest voice wins, the process is completely anonymous.
Oh, interesting.
Yeah, and it's structured in rounds.
Yeah.
The committee has sent a series of highly specific proposed standards. Like a statement might read, continuous pulse oximetry must be used during every infusion.
Okay, so a very hard rule.
Exactly. Then the experts vote on whether they agree, disagree, or suggest modifications. The results are aggregated, comments are summarized, and then the revised statements are sent back out for a second round.
So they just keep going until they agree.
Right. They repeat the cycle until they hit a very high threshold of undeniable consensus.
That makes a ton of sense. But I do look at the composition of that committee, and I see psychiatrists, anesthesiologists, emergency medicine doctors, psychotherapists.
It's a big mix.
It is. And I hear treatment for depression, and my initial thought is, why is it so crucial that this committee was interdisciplinary? Wouldn't a group of just psychiatrists have been enough to write the rules?
You'd think so. But if you only have psychiatrists writing the rules, you are ignoring the physical reality of a dissociative anesthetic.
Because it affects the body so much.
Right. Ketamine sits squarely at the intersection of mind and body. A psychiatrist understands the nuances of major depressive disorder, trauma integration, psychological safety.
Which is huge.
It is huge. But an anesthesiologist or an ER physician understands airway management, drug metabolism, and pharmacology at a granular level.
So you really need both sides in the room.
Exactly. During a Delphi round, a psychiatrist might propose minimizing medical equipment to reduce patient anxiety.
Keep the room calming.
Yeah, but an anesthesiologist will counter that a continuous blood pressure monitor is non-negotiable for physiological safety. The final guideline reflects that necessary compromise.
Creating an environment that is psychologically soothing, but medically locked down.
Precisely. You need the full spectrum of medical professionals to cover the mind and the body.
And that dual focus on mind and body is incredibly apparent in the first major recommendation of these guidelines. It focuses entirely on what happens before the treatment even begins.
Right, the intake.
Yeah, the comprehensive evaluation. It's basically like running diagnostics on a car before a road trip. The guidelines mandate that a clinic cannot just take your money and put you in a chair.
They absolutely cannot.
They have to establish clinical suitability through an exhaustive medical and psychiatric history.
Patient selection is the primary filter for risk here. On the medical side, the clinician is actively hunting for red flags.
Like what kind of red flag?
Well, they need to know if you have a history of aneurysms or uncontrolled hypertension. Because that transient blood pressure spike from the drug, it could be catastrophic for those patients.
Oh, wow, right?
They also have to look at liver function. Ketamine is heavily metabolized by the liver, so if a patient has severe hepatic impairment, the drug could build up to toxic levels.
Okay, and on the psychiatric side?
The filter is equally strict there. Ketamine is highly effective for unipolar depression, but it can violently exacerbate active psychosis or mania.
So you really need to catch that ahead of time.
Exactly.
Now, the evaluation also requires the use of standardized scales, like the PHQ-9, to measure the severity of the depression before starting.
Yes, it does.
And I want to push back on this a bit, because reducing a patient's pain to a 9-question checklist feels incredibly bureaucratic. Why are standardized scales necessary? For the listener going into a clinic, shouldn't a doctor just be able to talk to them to see how depressed they are?
I mean, human conversation is vital, obviously. But human memory is notoriously unreliable, especially when it's clouded by severe depression.
Oh, really? In what way?
There is this phenomenon called state-dependent memory. When you are deeply depressed, your brain literally struggles to remember what it feels like to be happy.
That's so true.
And conversely, when you are feeling good, you quickly forget the physical weight of the depression. So the PHQ-9, the Patient Health Questionnaire, asks for specific frequencies.
Like tracking actual days?
Right, like how many days in the last 2 weeks have you had trouble falling asleep? How often have you felt like a failure? Establishing that hard, objective baseline is the only way to hold the treatment accountable.
Okay, so it gives you actual data to compare.
Exactly. If we rely entirely on the patient saying, I think I might feel a little lighter, we don't have medical data. We need to track the numbers session by session to prove it's yielding tangible results.
And if the numbers don't change?
If the numbers don't move, the clinician knows they need to change the protocol or stop taking the patient's money.
Wow. Okay, so it shifts the questionnaire from being a bureaucratic hurdle to a literal mechanism for accountability.
Exactly.
So assuming the baseline is set and the patient is medically cleared, we move to the physical mechanism of the treatment itself.
The actual ride.
Right. The guidelines define the standard protocol for treating depression as an induction series of 4 to 6 intravenous infusions, usually clustered over 2 to 3 weeks. Why cluster them?
Because we are not just trying to temporarily numb the patient's emotional pain. We're actually trying to force the brain to physically rewire itself.
Literally rewiring.
Yeah. Ketamine triggers a massive surge of glutamate, which is the brain's most prominent excitatory neurotransmitter. This surge sets off a cascade that releases something called brain-derived neurotrophic factor, or BDNF.
Which is kind of like fertilizer for the brain?
That is exactly how you can think of it. It stimulates synaptogenesis, the actual physical growth of new dendritic spines and neural connections.
That's incredible.
But you do not grow a new neural network from a single exposure. The clustered induction series is required to sustain that fertilizer in the brain long enough for the new pathways to solidify.
So the depressive symptoms actually lift long term.
Right.
Now, a key component of that series is dose titration. When I hear titration, I just assume a clinic calculates a standard low dose based on my body weight and then keeps me there for all 6 sessions to guarantee safety. Is that not the standard?
Keeping the dose stagnant is a really common mistake in poorly run clinics. Weight-based calculations just give us a starting line.
Oh, really?
Yeah, because every single brain metabolizes this drug differently. Titration is the delicate process of starting at that safe, low baseline and then systematically increasing or titrating the dose up in the following sessions.
So you're adjusting it as you go.
Right. We are hunting for the Goldilocks zone. If the dose is too low, you don't trigger the glutamate surge, and the patient gets absolutely no relief.
But if it's too high?
If the dose is too high, the patient might experience severe anxiety or heavy sedation. The clinician must adjust the dial based purely on the patient's subjective experience of the previous infusion.
Which highlights exactly why the medical monitoring requirements in these guidelines are so uncompromising. If you are pushing the dose higher each session to find that edge, you have to watch their physical vitals like a hawk.
You absolutely do. The guidelines draw a very hard line here. If you are receiving an infusion, there must be an automatic blood pressure cuff taking readings at regular set intervals.
Okay.
And there must be continuous pulse oximetry, meaning a monitor tracking your heart rate and oxygen saturation every single second of the treatment.
But all that equipment is useless without the right personnel in the room.
Exactly.
And the ASKP3 mandates that the person monitoring you, or immediately available in the facility, must have an ACLS certification.
Advanced cardiovascular life support, yes.
So let's break down why that specific acronym matters. If a listener is looking for a clinic tomorrow, what specific personnel qualifications or monitoring equipment should they be looking for in the room based on these rules? What does ACLS actually mean in a worst-case scenario?
Well, basic CPR training is just about keeping blood pumping until the paramedics arrive. ACLS is an entirely different echelon of medical intervention.
Like ER-level intervention.
Pretty much. If a patient has an unexpected severe adverse reaction, say their blood pressure skyrockets to 210/120 and they go into a hypertensive crisis, or their airway becomes compromised, an ACLS-certified provider is trained to interpret the electrocardiogram in real time.
Wow, okay.
They can push the appropriate emergency intravenous medications, and they can secure the airway.
And if a clinic doesn't have that?
If a clinic employs staff who are only basic life support certified, they're relying on 911 as their primary backup plan.
That's terrifying. You do not want to be in a dissociative state waiting for an ambulance to figure out where you are.
You really don't.
That is the exact kind of tangible detail a patient needs when evaluating a provider. So we've established the physical risks are real. They require intensive monitoring.
Right.
But what about the psychological risks? If a patient is about to enter an altered state of consciousness, we have to talk about how we ensure they actually understand what they're signing up for. The guidelines place a massive emphasis on informed consent.
They do. And real informed consent is not a digital waiver you just scroll past and sign on a tablet in the waiting room.
Right, it's not terms and conditions.
Exactly. It has to be a granular, face-to-face conversation. The clinician must explicitly discuss the psychological intensity of the drug.
Because it can be overwhelming.
A patient needs to know that they might experience profound dissociation. They might feel completely detached from their physical body or their environment.
Which, honestly, some people might find peaceful.
True, but some find it absolutely terrifying. The patient has to know that going in. Furthermore, the clinician is ethically obligated to discuss the alternatives.
Right, because it's not the only option.
Exactly. Ketamine is a powerful tool, but it is not the only tool for treatment-resistant depression. The patient must be briefed on things like transcranial magnetic stimulation, electroconvulsive therapy, or different classes of traditional antidepressants.
So they have the full picture.
Right. They must understand their options so their choice is genuinely autonomous.
Now, I want to pivot to the controversies a bit, because the most interesting part of any rule book is often what the authors deliberately chose to leave out.
Hot topics.
Exactly. We know the reality of the landscape out there. Clinics are currently using intravenous ketamine to treat chronic pain, PTSD, OCD, severe anxiety. Yet, the ASKP3 guidelines isolate their recommendations almost exclusively to depressive disorders.
They really focused in on depression, yes.
So I have to ask, if ketamine is being used off-label for other conditions anyway, why wouldn't the experts include recommendations for those? Why isolate depressive disorders?
It really comes down to the integrity of the data and the mechanics of the treatment itself. Well, the scientific evidence supporting intravenous ketamine for treatment-resistant depression is incredibly robust. It's peer-reviewed and replicated across multiple massive trials.
And the other conditions aren't there yet.
Right. The evidence for PTSD and OCD is incredibly promising, but the data pool is simply not as deep yet. But beyond the data, the real issue is the actual pharmacology of treating different conditions.
Like the actual dosing.
Exactly. Take
Mhm.
chronic pain, for example. Treating complex regional pain syndrome with ketamine does not look anything like treating depression.
Really? I assumed it was the same process.
Not at all. A depression infusion might take 40 minutes at a relatively low dose,
Mm.
but a chronic pain infusion might require an overwhelmingly massive dose, administered continuously over 4 or even 6 hours.
Oh, wow. You definitely can't use the same safety manual for a 40-minute outpatient trip and a 6-hour intensive procedure.
Precisely. The physiological toll of a 4-hour high-dose infusion changes the safety profile entirely. If the committee tried to write a single set of guidelines encompassing the specific dosing, monitoring, and psychiatric support needed for depression, chronic pain, and OCD all at once, the rules would become so broad and diluted that they would be useless.
So, by isolating depressive disorders, they lay down a concrete, indisputable foundation.
Exactly. And as the clinical trials for chronic pain and PTSD mature, the guidelines will inevitably be updated to include specific, tailored parameters for those conditions.
That makes perfect sense. Zooming out from the mechanics of the clinic, though, the implementation of these guidelines triggers a massive ripple effect across the entire mental health care system.
It really changes the whole landscape.
Right. Creating standard rules doesn't just protect the individual sitting in the chair, it fundamentally alters who gets access to the chair in the first place.
Because right now, access is heavily gated by wealth. It is largely a cash-pay system.
Which shuts so many people out.
It does. Major insurance companies look at an unstandardized, off-label treatment with varying protocols from clinic to clinic, and they just refuse to cover it.
Because insurers rely on predictability.
Exactly. They need standardized billing codes attached to standardized medical outcomes. So by publishing and enforcing these guidelines, the ASKP3 is signaling to the wider medical and insurance communities that this modality is self-regulating.
It's professionalizing the whole industry.
Right. As more clinics adopt these strict parameters, the industry builds an enormous unified data set of safe, predictable outcomes. And that data is the exact leverage required to force insurance providers to the table.
Which is amazing because it transitions the therapy from this experimental luxury out-of-pocket expense to a standard medical intervention accessible to anyone suffering from severe depression.
Absolutely.
But I mean, this also puts immense pressure on the clinics operating today. Providers who've been treating this like a side hustle are going to have to invest real capital.
Oh, for sure.
Upgrading monitoring equipment, hiring ACLS-certified staff, rethinking their whole intake evaluation, or they're going to get squeezed out of the market by the new standard of care.
The industry is definitely going to experience a necessary contraction. The clinics prioritizing volume over safety will struggle to adapt.
And they probably should.
Right. While the clinics prioritizing rigorous medical and psychiatric protocols will become the blueprint for the future. I mean, we are still in the early stages here.
We still need a lot more research.
Exactly. We need extensive longitudinal data on the long-term cognitive effects of repeated use over years. The policy landscape is going to have to adapt continuously. But elevating the baseline requirement for patient safety is really the only way this treatment survives.
I completely agree. And before we go, I want to leave you, the listener, with a final provocative thought to ponder.
Let's hear it.
We have just unpacked how the medical community is successfully creating rigorous structural safety nets for a substance that a decade ago was considered completely fringe in the psychiatric world.
Oh, absolutely fringe.
So if we are successfully transitioning ketamine from the Wild West into a standardized, highly regulated medical practice, how might this change society's overall perception and acceptance of other alternative emerging mental health therapies in the future?
That is a fascinating question.
Right. Like, if this blueprint works, what does that mean for the next wave of psychiatric breakthroughs currently waiting in the wings?
It really suggests that the boundaries of traditional psychiatry are expanding much faster than we ever anticipated.
So it sounds like these guidelines offer a solid foundation for a more responsible and ethical ketamine therapy, but they're just a starting point.
Exactly. These guidelines are a major step towards ensuring safer and more effective treatment for depression.
Progress. Thanks for listening to the Talking Ketamine podcast. We'll catch you on the next one.